you to Aki Smith and Hope for Stomach Cancer for inviting me to participate in this online educational symposium. My name is Sam Klempner. I'm a GI medical oncologist at Massachusetts General Hospital in Boston. My clinical and translational research is focused in gastric and esophageal cancers. And I'm really here today to discuss how medical oncologists participate in regional therapy discussions. Here are my disclosures. I'd like to recognize our grant support from the NCI, AACR, and Stand Up to Cancer, the AGA, and the Gastric Cancer Foundation, all of whom are working to advance the care in stomach cancer. So in the next 10 minutes, we'll be discussing the role of the medical oncologist in regional gastric cancer therapies, particularly intraperitoneal therapies, including intraperitoneal chemotherapy, Hipec, and Pipac. Start with a brief anatomy lesson to help understand the scope of the problem. Then we'll discuss some of the roles of the medical oncologist in patient considerations. Finally, we'll conclude with some questions that I think are relevant to ask your team when you're considering regional therapies. After this lecture, you'll hear from 3 regional therapy experts, Dr. Yanghee Woo, Dr. Brian Badgwell, and Dr. Andrew Blakely, who will delve a lot deeper into the specific approaches. So the organs of the chest and the abdomen are surrounded by a very thin layer of cells called the peritoneum. This lining essentially helps to separate and protect organs and provides a surface for a gut to really slide over itself during normal function. I often think of this like saran wrap around a meat, hence this picture here. The peritoneal lining is continuous and has a parietal component that lines the inner surface of the abdomen and the visceral component that wraps around the abdominal organs and all the crevices. There's normally a very small amount of fluid in the peritoneal cavity, and you can think of this like a lubricant. This picture here is what a peritoneal lining normally looks like. And you can see this shiny surface here sort of tightly wrapping all of the organs. And here you see the gut as well as the liver. And this is from a diagnostic laparoscopy in someone without any peritoneal disease. Cancer spread to the peritoneum is common in several cancers and develops in up to 50% of patients with stomach cancer at some point during their disease course. Symptoms are very nonspecific, and this is another reason that peritoneal disease is often hard to diagnose. The pattern of spread is often diffuse with numerous small nodules distributed throughout the peritoneal cavity. The nodules are often only a few millimeters in size, and as you see again in the upper panel here, see very clean, smooth surface with no speckling. In the lower frame, which is taken from a picture of a patient with stomach cancer and peritoneal disease, you see these small whitish plaques, often compared to sort of throwing grains of sand on a countertop, although there's multiple analogies, but you can see that these are all very little small things that would be otherwise difficult to see and difficult to feel. One thing you might be thinking based on the appearance of peritoneal disease is that it would be difficult to see on any testing, and that's true. And so here we'll talk a little bit about staging. And really the goal of any cancer staging is to understand the extent and the locations of the disease. The reason is that this is very important because we can clearly separate patients into survival groups based on the burden and locations of disease. These groups are called stages. Patient with a very superficial tumor and no lymph nodes, like a stage 1 cancer, the top black line in this figure, treated with surgery alone may have a greater than 90% survival at 5 years, whereas a patient with a larger tumor and positive lymph node involvement, say stage 3, might have a less than 50% chance of being alive in 5 years. This is very important because someone with a 90% survival might not benefit from adding any therapy, whereas there's a clear need to do something to try and improve the survival for the stage 3 patient. Again, this slide really speaks to the importance of directly visualizing the peritoneum. As I mentioned, it's very difficult to visualize the peritoneum on our current tools, including CAT scans, PET scans, and MRI. We really cannot evaluate the peritoneum well at all. This is really a key point. It's It's often missed during the initial workup of stomach cancer, unfortunately. In fact, if you look at some series, the rates of peritoneal disease approach 30% for patients with T2 or higher tumors. As you can see here in this snapshot from the NCCN guidelines, the NCCN currently recommends peritoneal evaluation with a diagnostic laparoscopy, which is an outpatient surgical procedure, to directly visualize the peritoneum for stomach cancers that are T1b or higher. Again, the goal here is really to get the most accurate staging, since peritoneal disease or positive cells in the peritoneal washings, often called cytology, defines metastatic disease that you can't see on a scan. So this is really an important point. As physicians, our first job is really to do no harm. Anytime we consider a therapy, we really want to understand as much as we can about who it might help and who it probably won't help. In order to do this in a multidisciplinary team setting, we need to really make sure that we're all speaking the same language. In discussing data and thinking about patient selection, the Peritoneal Carcinomatosis Index, or PCI, is one of the tools we use commonly. Just like we talked about staging, a patient with large or bulky tumors throughout the peritoneum may be a less ideal candidate for peritoneal approaches than a patient with a few small lesions confined to one area of the abdomen. So when we examine patients that we treat with regional therapies, we look for patterns. If patients with a peritoneal carcinomatosis index of, say, less than 15 are not getting any benefit from the therapy, then we need to think about whether or not the next patient who comes in with a very high score should even be considered for these approaches. Or perhaps this is someone that needs another therapy first and then a repeat evaluation. So what's shown in this slide is really a graphic describing how the surgeons, when they look around the abdomen, score the peritoneal cavity to give us an assessment of burden of disease, kind of the same way we as medical oncologists often look at CTs and PET CTs to get a sense of burden of disease with things we can see on a scan. So one of the key barriers to improving therapy for peritoneal disease is really the lack of understanding of the biology of the peritoneal cavity. Cells that survive here in the abdominal cavity need to adapt to a different environment and differ substantially from the primary tumor. In fact, some small series have suggested that the biologic programs that are turned on in peritoneal disease are also associated with intrinsic resistance to our common therapies. Similarly, we honestly don't have a great data to understand how well the drugs we give in the veins penetrate into the peritoneal cavity. It's quite likely that we may actually identify peritoneal specific targets or the ability to manipulate the immune kind of soup that lives in the peritoneal cavity. There's actually several projects available where patients around the United States can actually contribute to this effort. For example, the ESC project through the Rare Cancer Research Foundation and Count Me In. Patients can essentially go online to these websites, fill out a brief consent, and if they happen to be going to have a fluid drainage, the fluid can actually be sent for analysis and attempts to grow a patient-specific model of the cancer so that all research can actually study this. I certainly have tried to do this for my own patients. In fact, over here on the right is a picture that's actually resulting from some research we're doing, sponsored by the AGA and Gastric Cancer Foundation, to try to understand the peritoneum. And here what you see in this picture is tumor cells are marked by a surface protein called EpCAM, so they're outlined in blue in this figure. Immune cells are the red cells, and as you can see in this sample, there's not very many of them. So you might think that immune therapy may be slightly less effective in someone with peritoneal disease. Again, this is something we still need to study. And the other markers are really marking dying cells that are dying in the processing. Well, finally, when we as medical oncologists talk to patients, we know that stomach cancer is a very heterogeneous disease, and everyone's cancer is different. Anytime we're considering therapies that are not standard, we're really obligated to gather as much information as possible to make an informed decision and a shared decision with our patients. And the same is definitely true for peritoneal disease. I think many of us would agree that patients who are rapidly progressing through our best chemotherapies or have a very large burden of disease and bulky peritoneal tumors, or disease outside of the peritoneum, like multiple lung metastases or liver metastases, may be less likely to benefit from regional therapies. This also speaks to the issue of defining benefit. We have to go in with realistic expectations and understanding, are we hoping to hit a home run and therefore tolerate perhaps a more toxic therapy? Are we hoping to prolong symptom control and delay the time to the development of ascites, for example, which can be highly symptomatic? Are we truly trying to palliate symptoms related to the peritoneal disease? These are all very important questions when you meet with the multidisciplinary team. And I just left some important ones here that I think are worth discussing with your surgeon and your medical oncologist, your radiation oncologist. We have multiple tools, and peritoneal therapies may indeed be one tool and may be the right tool in certain situations. But we really need a team effort to choose patients wisely and making sure that we all understand the goals and what we're going in to attempt to do. So in anticipation of the more detailed lectures that will follow from our three surgical experts, I really have tried to give a brief refresher on the peritoneal cavity so that you really have a framework to understand the nuances of intraperitoneal therapies, Hipec and Pipac, which will be discussed shortly. We talked about the importance of evaluating the peritoneal cavity as part of staging, and please, for patients that are newly diagnosed, please discuss this with your treatment team. We see multiple cases a year where patients are unaware of peritoneal disease at diagnosis, only to find it when patients go to the operating room for a curative intent surgery. We talked about an urgent need, in my opinion, to better understand stomach cancer peritoneal biology, to really move the field forward. So we're selecting the best treatments to give into the peritoneum. Finally, we talked a little bit about how medical oncologists think and interact with the surgical teams, and I provided a list of questions to help guide these discussions that I think are important. I would also like to stress research participation. Really, the way that we learn how to advance the care of patients with peritoneal disease is through clinical trials and through sample gathering and translational projects. And so I would encourage you to ask your treatment team if there's opportunities locally. If not, there are opportunities nationally, and I provided a couple websites where patients can provide material such as acidic fluid that would otherwise just be discarded. And this is done in a de-identified manner. Finally, I'd just like to thank you all again for your time and attention. I hope this was informative. I'd be happy to take further questions during the question and answer period. And I've provided my contact information here for reference. And Hope for Stomach Cancer has an excellent website full of very important information as well. Thank you very much.